Assalamu alaikum. Hello everyone. My name is Dima Jamil and this presentation is prepared in collaboration with the IAO Dermatology Club. Before we begin, let's briefly go over the objectives. By the end of this video, you should be able to understand the meaning and pathogenesis of acne vulgaris, recognize the clinical features and diagnostic approach, be aware of its complications, differential diagnosis, and basic management principles. Acne vulgaris is one of the most common dermatologic conditions we encounter, especially in adolescents and young adults. It can affect both the physical appearance and the psychological well-being of patients. That's why making early recognition and the treatment are very important. By definition, acne vulgaris is a chronic multifactorial inflammatory disease of the pilosebaceous unit. It's characterized by a combination of lesions such as comedones, papules, pustules, nodules, and sometimes cysts. The most commonly affected sites are the face, chest, and upper trunk, where sebaceous glands are most active.
Now with the clinical features of acne. Acne most commonly occurs in areas that are rich in sebaceous glands. That is mostly the face, neck, and upper trunk. Now, although inflammation is present early in the disease, acne is clinically divided into two main groups, inflammatory and non-inflammatory acne. Non-inflammatory acne includes closed and open comedones. Closed comedones, or more commonly known as whiteheads, are tiny skin-colored papules around 1 millimeter in size. These comedones do not have a visible opening and they can be quite subtle, so they're best seen with a palpation or stretching of the skin. Open comedones, or more commonly known as blackheads, have a dilated follicular opening that is filled with keratin debris. The dark or black color is due to melanin deposition and oxidation of the lipids within the plug. Now, if one of these comedones undergoes rupture, or if the bacteria Propionibacterium acnes enters the follicles, an immune response can occur, turning them into the inflammatory type. Inflammatory acne can have many different presentations. First, there are papules. Papules are small erythematous lesions about 1 to 5 millimeter in size. These papules can then turn into pustules. Pustules are of similar size, but they're filled with pus containing Propionibacterium acnes and other normal skin flora. Now, as severity progresses, nodules can form. Nodules are even larger, they're more tender, and they're indurated. Then deeper lesions called pseudocysts may develop. These pseudocyst lesions contain pus and serosanguinous fluid. When these pseudocyst lesions kind of coalesce, they form large inflamed plaques, and that is when we call it severe nodulocystic acne. These large inflamed plaques can even have sinus tracts, and here is an example of how it can look like.
Now, let's move on to the diagnosis. The diagnosis of acne vulgaris is mainly clinical, and that's a key point. We rely mainly on a good history and through physical examination. There are no specific lab or imaging tests that confirm acne, and a skin biopsy is rarely required here. Also, we only order tests when the presentation suggests something beyond simple acne. When taking the history, think of it as telling the story behind the acne. When it started, what might have triggered it, and what it might be related to. Let's go point by point. Age of onset and current age. Ask about when the acne started and the patient's current age. Early onset, for example, before puberty, can suggest hormonal problems, while sudden late onset acne in adulthood can raise suspicion for drug-induced or endocrine-related acne such as in PCOS. Medication history. Always ask about current or recent medication. Drugs like corticosteroids, androgens, lithium, or anticonvulsants can cause acneiform eruptions that mimic acne vulgaris, but require a different approach. Menstrual history in females. This helps assess hormonal influence. because irregular cycles or flares around menstruation may point toward hyperandrogenism or PCOS. Family history. Acne often runs in families due to genetic predisposition. So, a positive family history can explain more severe or persistent cases. Sign of virilization. Ask about hirsutism, deepening of the boys, or male pattern hair loss, especially in women and children. These features suggest androgen excess, which may require hormonal evaluation later. Joint or bone pain? This might sound unrelated, but in patients with severe nodular acne, it could indicate Sappho syndrome, which links acne with arthritis and osteitis. Skincare habits and the product used. We should ask about creams, oil, or cosmetics. Many contain comedogenic ingredients that worsen acne. Changing these can be part of a treatment itself. Previous treatment and response. This helps us understand what's been tried and whether the acne is treatment resistant or possibly non-compliant. Finally, psychological impact. Never forget the emotional side. Even mild acne can cause stress, embarrassment, or low self-esteem. Acknowledging this can improve adherence and patient trust. Once we have the history, we move on to the physical examination, which confirms our impression. Here, we focus on two main things: what lesions are present and where they are located. Typically, we see comedones, papules, pustules, and nodules, most commonly on the face, chest, shoulders, back, and upper arms. Next, assess the severity and pattern. In acne vulgaris, lesions are usually polymorphic, meaning they appear in different stages of development and healing. If the lesions are all the same and appear suddenly, that's more consistent with drug-induced acne or malassezia folliculitis. We also check for signs of hyperandrogenism, such as excess hair growth, and for post-acne changes like hyperpigmentation or scarring, which help in grading severity and planning treatment. And a very practical teaching tip: if you see comedones, that's your strongest clue you are dealing with acne vulgaris. Now, let's talk about when investigations are actually justified. Remember, most patients with acne vulgaris don't need any tests. However, there are a few important scenarios where further workup is indicated. 1. Hyperandrogenism. We suspected hyperandrogenism in patients with irregular or infrequent menses, hirsutism, virilization, or early onset severe acne. In these cases, we order hormonal tests to identify possible causes like PCOS, congenital adrenal hyperplasia, or adrenal or ovarian tumors. Recommended tests include total and free testosterone to assess androgen levels, DHEAS elevated in adrenal causes, LH and FSH suggestive for PCOS, 17-hydroxyprogesterone to screen for congenital adrenal hyperplasia, prolactin and TSH to rule out pituitary or thyroid causes, pelvic ultrasound to evaluate for polycystic ovaries or ovarian masses, adrenal imaging such as CT or MRI if labs suggest an adrenal source of androgen excess. 2. Acne fulminans. This is a severe acute inflammatory form of acne that often presents with systemic symptoms. Before starting isotretinoin therapy, baseline labs are essential here. Recommended tests include CBC to assess for anemia, leukocytosis, or infection, liver function test, lipid profile, since isotretinoin can raise lipid levels, ESR and CRP to monitor systemic inflammation, and serum or urine pregnancy test required for female before isotretinoin. 3. Sopho syndrome. It should be suspected when nodular or severe acne occurs with bone or joint pain involving the chest wall. Recommended tests include inflammatory markers, ESR and CRP to look for systemic inflammation, bone and joint imaging, X-ray or CT scan of the chest wall, clavicle or sternum, MRI, which is more sensitive for early bone marrow and joint involvement, and bone scan, which is a nuclear medicine, can help identify multiple skeletal lesions if SFO is suspected.
Hello everyone, my name is Latifa. We have now reached our final objective, which is management of acne vulgaris. So the management strategy is based on treating the 4 key pathogenic mechanisms of acne, which as you can see in the table. So we have follicular hyperproliferation and abnormal desquamation. The active agent for this pathogenesis are topical retinoids, oral isotretinoin, azelaic acid, and salicylic acid. For increased sebum production, we would use oral isotretinoin and oral contraceptives, spironolactones. For Propionibacterium acne, which is a type of bacteria, we would use benzoyl peroxide, topical and oral antibiotics, azelaic acid. For inflammation, we would use oral isotretinoin, oral tetracyclines, topical retinoids, azelaic acid, and topical dapsone. Okay, before we choose a treatment, we have to do a thorough assessment. First, we will look at the type of lesion. So, is it comedonal? Is it inflammatory papule or pustule? Or is it a nodule? Then we will assess the severity. I will discuss it in the next slide. Then we will look at the presence of complications such as post-inflammatory hyperpigmentation or post-inflammatory erythema, scarring, psychological distress. And we will look for any contributing factor such as comedogenic skincare products, acne-inducing medication, or any sign or symptoms of endocrinal disorders. Okay. For grading, it could be mild acne vulgaris or it could be moderate to severe. So the lesions in mild are typically comedonal, both open and closed. There are a few small inflammatory papules. The most important things here is the absence of scarring, absence of nodule, and the involvement is limited. It's not widespread or confluent. So here, as you can see multiple clogged comedones and small papules over the forehead. For moderate to severe acne, the patient have many comedones and papules. They also have nodules, scars, and it involves multiple body areas, not just a scattered lesion as mild acne. So as you can see in this picture, it is severe nodular acne over the face. Okay, for the patient counseling, we have to inform the patient that improvement is often delayed. In general, to assess the treatment efficacy, it has to be at least 2 to 3 months of consistent adherence, and the initial response is a notable reduction rather than complete clearance of the active lesions. Sometimes we would need to adjust the medication, and long-term maintenance treatments is often necessary. We would ask the patient or inform the patient to use gentle cleansers rather than soaps or scrubs. We would ask them to avoid aggressive scrubbing and select non-comedogenic skincare products and cosmetic products. We would ask them to avoid puking of the acne lesion as it could lead to scars or post-inflammatory hyperpigmentation. The diet role is still unknown. Okay, for mild acne vulgaris treatment algorithm, topical therapy